So we are going to be doing, let me just put this out of the way. Hold on. Okay. So the spongiotic psoriasiform and interface diseases is what we are going to be starting with. So last week we had the introduction of like basic stuff. It's taking a minute to load. Okay. So we did talk about spongiosis and what it really means, and that it is a very common reaction pattern that you guys basically encounter. So spongiosis is largely refers to fluid in the epidermis, and the presence of fluid is manifested in the form of this inflammatory cell exocytosis, prominence of the desmosomes. We talked about this last week. So you can see that there is space in between the epidermal keratinocytes, the prominence of desmosomes, there are inflammatory cells pouring out along with this. So it's inflammatory cell exocytosis, and there is this active crust formation. So those three things form a spongiotic entity. Now, when you mean spongiosis, you're most often referring to an eczematous dermatosis. The eczema clinically could be nummular, atopic, contact, steatotic, stasis, dyshidrosis. Basically, all of them will produce this reaction pattern of spongiosis with a superficial perivascular infiltrate. Now, it's pretty traditional to describe or quantify the amount of spongiosis on a biopsy. So acute spongiotic means to active spongiotic changes with dermal edema and presence of these intraepidermal spongiotic vesicles. So you can see the nice dermal edema and these intraepidermal spongiotic vesicles. So this is something that would actively blister in the patient. That's acute spongiotic. Over a period of time, largely the inflammation would subside. So you get subacute spongiotic. So you do get, there are not any active blisters formation, but you do see the crust, some microvesicles. There is inflammatory cell exocytosis. So this is a subacute spongiotic pattern. Then lastly would be the chronic spongiotic, which would just be manifestation with minimal spongiosis. You see epidermal acanthosis with hyperkeratosis, hypergranulosis, and a superficial perivascular infiltrate. So it's pretty non-specific, a chronic spongiotic pattern. The board questions that they like to ask you, number one would be the LSC or prurigo nodularis. This is a very important board question. They both will have identical features on histology. So LSC and prurigo both look the same. They essentially come in the category of chronic spongiotic diseases because you see everything in the epidermis is thick, acanthosis, spongiosis, hyperkeratosis, parakeratosis, but they do have some distinct recognizable features. You see these follicular hypertrophied infundibular units. You can see these thick hair follicles, these vertically oriented papillodermal fibers, and these vessels which are oriented perpendicular to the epidermis. So all these epidermal changes are classic for LSC or prurigo. This is a very important board entity. They will ask you to distinguish this from a wart, and you should know the hypertrophied follicular infundibular units, these stretched out vessels, and the dermal fibers which are oriented perpendicular to the epidermis. So that is LSC or prurigo. Okay. So now let's talk about the other things that are going to be asked in your boards. And so one of the things is they can just ask you they can show you this particular slide. And you can see here the reaction pattern is spongiosis. You see inflammatory cell exocytosis, crust, a superficial perivascular infiltrate. So this would be primary eczema. So it would be nummular, contact, anything. So they can ask you to recognize a primary eczematous dermatitis, and that you will recognize it from the epidermal changes and a superficial perivascular infiltrate. The next thing that they can specifically ask you is like allergic contact dermatitis. So allergic contact dermatitis, it looks like a spongiotic derm. So you can see the microvesicles. But when you see these spongiotic microvesicles, which have these Langerhans cells, as you see in here, these are the antigen-presenting cells. They have lots of pink cytoplasm. Then you would think about a primary spongiotic consistent with contact. You can even see the dermal eosinophils in the biopsy here. So they can ask you primary eczema, and they can ask you specifically contact, which you will recognize from the spongiotic microvesicles. Okay, now let's go to your the next reaction pattern. This is a biopsy from acral skin, and what you can see in here is the thick stratum corneum with a lot of spongiotic fluid-filled vesicles on the epidermal skin with the dermal edema. So this pattern of acute spongiosis on the acral sites is dyshidrosis or pompholyx. So dyshidrotic eczema or pompholyx is what this would look like. So this is dyshidrotic derm or pompholyx, very, very important board entity. The next one in the eczematous derm, which is asked, is stasis derm. Stasis dermatitis is characterized as a chronic eczematous dermatitis. So you can see a thick epidermis on top with not a lot of active spongiosis. But what you see in the dermis are these cannonballs. So you can see the lobulated proliferation of these small sized thick walled vessels in the dermis with variable degree of dermal edema and fibrosis. So you can see even some extravasated red blood cells. Now, this is a really important entity. This would be the similar histologic findings for acroangiodermatitis. So acroangiodermatitis and stasis derm would both look the same. Acroangiodermatitis is something that clinically looks more pseudotumoral, like a plaque. So you can think about a tumor entity rather than a rash like in stasis derm, but the histology looks the same. Does everybody recognize those cannonballs? So they are lobulated, right? And with each lumen, you can make out a vessel. There is a lumen, there is a vessel. There is a lumen, there is a vessel. Lumen, there is a vessel. So lobulated proliferation of small-sized, thick-walled vessels. This is another example of stasis derm or acroangiodermatitis. You can again see the thick epidermis. You can see a nice cannonballs, lobulated proliferation. Notice that there is some mucinous change in the stroma behind, which is reactive. So you could, that's not the primary disease. So that's just reactive mucinous change. This pigment is all hemosiderin. This is chronic blood and hemosiderin, what you see in here. But this would be stasis derm or acroangiodermatitis. Okay, so coming to your next entity, what they like to ask on your boards. So this is a reaction pattern. Now, most of your derm pad diagnosis, as we will be going on and when we will review slides, you will have to be made at low power. So 4x is the power where I want you guys to stick to. It can be even lower when you're seeing slides on digitalized platform. So you can see here, this is actually 3x, and you can see the entire slide pretty well. And this is the power you want to stick. When you see a superficial and a deep lymphocytic infiltrate, that is one trick that I like to do. You want to go up on high power to look at the composition of the cells. And you're largely looking for the presence or the absence of eosinophils. So the eosinophils are the cells with these orange granules. Does everybody see those? These cells with the orange granules are the eosinophils. And when you see a superficial and a deep lymphocytic infiltrate with these many eosinophils, and then you back up and you see this dermal edema, it is almost certainly an arthropod assault. So what are the things which will produce eosinophils in the infiltrate? So you may want to write this down. It is A, B, C, D. So A stands for arthropod assault. B stands for bullous pemphigoid. C stands for contact dermatitis. And D stands for a drug eruption. And then you have uncommon entities, not uncommon, but other entities like urticaria or incontinentia pigmenti. So a superficial and a deep infiltrate, when you're seeing this many degree of eosinophils, this is almost certainly an arthropod assault. It's not contact derm, because in contact derm, you do not get a deep infiltrate. This is not BP again, because in BP, you do not get a deep infiltrate. A drug reaction is very non-specific. So you don't want to call something a drug reaction unless and until they're giving you a specific kind, like lichenoid drug reaction or fixed drug eruption. So drug reaction, otherwise, yes, anything can look like a drug reaction. So you don't want to call that. So if a superficial deep lymphocytic infiltrate, you see eosinophils, then you are dealing with an arthropod assault. If you do not see eosinophils, then what are the things that you deal with? And those are your L diseases. So number one is light related, including polymorphous light eruption or photodermatitis, light. The second one is lupus. The third one is Louis or syphilis. The fourth one is pleva. The fifth one is lichen striatus. Okay, so you see all of them have L's in them, right? So those entities will not have eosinophils, but there will be specific ways that we will recognize all of them, which we will study later on. So that is a broad category of how you approach a deep lymphocytic infiltrate. So this is arthropod assault. This is substantiated because this has dermal edema and spongiosis, so classic arthropod assault. The other scenario is easy when you see the tick part. So this is an arthropod assault where you're actually seeing the tick part in the skin. Okay. And then lastly is going to be what is referred to as the cone of cement. So here you can see there is a superficial and a deep lymphocytic infiltrate. And when you go up on high power, you are looking for the presence and the absence of eosinophils. And what you see in here are a ton of eosinophils. So this goes very much for an arthropod assault. But what you see in over here is what is referred to as the cone of cement. So I'm just going to quickly take this call, guys. Hello. Oh, where are you? Okay, I'm downstairs in the lobby room down, where the lobby is where we got I'm just teaching. So when I'm done teaching, then we'll go out for dinner, lunch. We will go out somewhere. Okay. Can you please, Rohan, you don't want to talk to the exhibitionist? Okay, bye. Okay, so this is what is referred to as the cone of cement. It's a eostophilic halonized structure, which is an old tick part. And the reason it is important to recognize this is because this is confused with the flame figure. And a flame figure, when you see in dermatopathology, you're thinking about Wells syndrome. Okay, so they will ask you this, and this will be Wells syndrome and arthropod, both of them in the differential diagnosis. So you should know how to recognize this is a cone of cement of arthropod and not the flame figure of Wells syndrome. So how does a flame figure look like? So a flame figure is degranulated eosinophils with basophilia of the tissue collagen. So it looks more, again, the background for both arthropod and Wells syndrome will have a lot of eos. But the flame, you see how the flame figure looks different? These are all degranulated EO, so it has basophilia and an orange appearance. It's not that really pink and halonized. Okay, so this is a flame figure which defines your Wells syndrome. Okay, so you should know how to recognize a flame figure from a cone of cement, which is your old tick part. Okay, so now let's continue with your spongiotic entity. So we talked about, okay, so now the next one would be, we've talked about arthropod. This is the next disease, and that would be your pernio. So pernio is chilblains, which is idiopathic chilblains, which occurs due to exposure to cold or extreme temperatures. And what you see is on acral skin, and you recognize this because there's stratum lucidum, and you see dermal edema with a perivascular lymphocytic infiltrate. Now, this again is a low power diagnosis. You do not want to go up on high power. Okay. This is you do not typically get any epidermal involvement in idiopathic pernio or chilblains. But if you go on high power, you will confuse yourself with vacuolar alteration. And things like chilblain lupus is a wrong diagnosis. So you don't want to pick that up. Okay. This is classic pernio, which is your cold phenomenon, which is your dermal edema with the superficial to mid or deep dermal perivascular lymphocytic infiltrate. Now, pernio can have some different features. So remember that pernio can have pericrine inflammation. So you can have inflammation around the sweat glands. You can see mucin in biopsies of pernio. So it's not uncommon. You can see mucin in biopsies of pernio. You can have pericrine inflammation as well. Okay, and just because you're seeing some subtle interface change is not going to make it chilblain lupus. Now, is that clear? Okay. Do you guys know of the association of pernio with celiac disease? If not, this is an important association that you guys should know. Pernio has a very high association with celiac disease. So when you're diagnosing pernio in a patient, it's kind of like important to make sure that, that you're not missing celiac disease in that patient. It's a very well-known association. So pernio and celiac disease. Okay, so now so pernio is an important board question. The other thing is pernio and polymorphous light eruption will both look the same. So pernio is the cold phenomenon, PMLE is the hot phenomenon. So polymorphous light eruption will look like pernio, plus because it is light, it can also look like other things. But whenever you see, so this is how you approach this biopsy. Now, for example, you again are having a superficial deep lymphocytic infiltrate, right? So you can go up on high power and you can look for the presence or the absence of eosinophils. And what I'm seeing over here is basically no eosinophils, right? So now then I'm in the 5Ls, the lupus, lichen stridus, syphilis, pleva, so on and so forth. So the reason this is not lupus is because I'm seeing dermal edema, right? So there is dermal edema and there is no chronic interface, which we will talk about later. So it's not lupus. You're not seeing any lichenoid change. The epidermis does not have any lichenoid change, what you would see in lichen stridus, right? So lichen stridus, you're seeing dermal edema, which is unlikely in syphilis. So that is also out. So this is a lymphocytic infiltrate, which is superficial and a deep with dermal edema and some spongiosis, which is consistent with PMLE. Okay, so this is also a really important slide. When you see a superficial deep lymphocytic infiltrate with no eosinophils, with epidermal spongiosis and dermal edema, we're again dealing with something light related. So this is PMLE. So that's the hot and the cold phenomenon. They will both produce, both Pernio and PMLE will produce your lymphocytic infiltrated non-vessels with dermal edema. Okay, now the next thing we are going to be talking about is pityriasis rosea. So there are three pityriasis diseases which are all kind of complicated. So we have pityriasis rosea, we have pityriasis rubra pilaris, and we have pityriasis lichenoides. So we will be talking about all those three entities today. So those are important board entities, but those are entities which we, not always think about right away when we see a slide, but you should remember about it. So pityriasis rosea, everything about that slide is subtle. It has very subtle background spongiosis, which is referred to as pityriaciform spongiosis. So it should not have any acute active vesicles or marked dermal edema. It should not have confluent hyper and parakeratosis. What it has is these mounds of parakeratosis, which are lifted up from the epidermis like the lid of a tea kettle. These mounds lifted up from the epidermis like the lid of the tea kettle. And it's a clean mound. Why is it a clean mound? Because you just see the nuclei, the parakeratotic nuclei, but you do not see any neutrophils. Okay. So you see the parakeratosis, the nuclei, but no neutrophils. So it's a clean mound. So a clean mound lifted up from the epidermis like the lid of a tea kettle, and it's a clean mound. And you can see that the inflammation is just superficial perivascular. You may have a couple of EOs, but it should not be a whole lot of inflammation going into the deep dermis. So that's pityriasis rosea. So delicate pityriaciform spongiosis. The background pattern is undulating epidermal acanthosis, so not very thick epidermis. But most importantly are these clean mounds of parakeratosis lifted up from the epidermis like the lid of a tea kettle, superficial perivascular infiltrate. Okay, so that is pityriasis rosea. Now, whenever you have PR in the differential on histology, you will always have guttate psoriasis, right? So the histology of both PR and guttate psoriasis will look same. So you can see that the background epidermis looks very similar. You have this nice spongiosis, some slight acanthosis, but unlike pityriasis rosea, you have a mound which is dirty. So a dirty mound and a stuck mound. So why is it dirty? Because this has the neutrophils besides the parakeratosis. So you see the neutrophilic debris besides the parakeratosis. But that makes it a dirty mound, and this is a stuck mound. Stuck mound because of the mound of parakeratosis, which is stuck to the epidermis directly with loss of glandular cell layer beneath it, and a dirty mound which is lifted up from the epidermis with neutrophils in it. So this is a dirty mound and a stuck mound. That is very pathognomic for pityriasis rosea. You can also see this. This is another mound and over here. So you can see this in here. So you can see this is a nice dirty mound, a mound of parakeratosis lifted up with the neutrophils in the cornified layer. So that is the dirty mound of guttate psoriasis. So they will just give you this slide and they will ask you to this screenshot, and you should be able to recognize guttate psoriasis from here. Okay, so what are the things we have covered in the spongiotic entities? We have talked about LSC prurigo. We have talked about recognizing primary eczema, which is nummular or contact. We have talked about dishydrosis, stasis dermatitis, arthropod bite reaction, Pernio, PMLE, pityriasis rosea, and guttate psoriasis. So those are all the board questions that are asked you in your eczematous dermatosis. Things like Gennady-Crosty syndrome or pityriasis alba or parapsoriasis or photoallergic drug eruption, photodrug eruption. They're all very non-specific things. So they are distractors in your multiple choice. So remember that. Okay, now let's come to your classic next reaction pattern, which is a psoriasiform pattern. So we talked about this last week as well. So what makes something psoriasiform is a pattern of the epidermal thickening. So psoriasiform epidermal hyperplasia has bulbous reedy ridges, these feet which are bulbous and swollen with the suprapapillary epidermal thinning and these dilated vessels present right beneath it. So you have psoriasiform epidermal hyperplasia with bulbous swollen reedy ridges with suprapapillary epidermal thinning, dilated vessels, Loss of granule cell layer. So what is happening in psoriasis is there's rapid cell turnover, right? So the body says, fine, I'm going to rapidly proliferate. I'm not going to form the granular cell layer. So you see the loss of granular cell layer, you see hyperkeratosis and parakeratosis, and these are the neutrophils in the cornified layer, which is your Munro's microabscess. So you can see these Munro's microabscesses in here. So you can see the nice psoriasiform hyperplasia, bulbous VT ridges, suprapapillary thinning, dilated vessels, loss of granular cell layer, hyperkeratosis, parakeratosis, and neutrophils in the cornified layer. That is your classic silver plaque of psoriasis, which basically, it's not as classic like this always, right? Most of the times when you're biopsying psoriasis, it has atypical features. But what they're going to ask you in your boards is the classic silver plaque of psoriasis, which is this. Okay, so the other thing is that if this looks like this, but you do not have psoriasis in your multiple choice, so then things like Vitus syndrome or keratoderma bledoragicum will look like psoriasis. So remember, those are entities which is, are infectious entities. They are reactive arthritis, syndrome. That's keratoderma bledoragicum is a skin rash of that, which looks indistinguishable from psoriasis. There is another type of psoriasis which is less common, which we will talk about in the next class, which when we are talking about blistering diseases, and that is your subcorneal blister with neutrophils. So you can see this nice pustular psoriasis variant where you do not see the psoriasiform hyperplasia. What you're seeing is a subcorneal intraepidermal blister with neutrophils. So that's the pustular psoriasis variant. This one is common. It's not that common as your classic silver plaque psoriasis, but it can happen. It can happen in pregnancy when it is called impetigo herpetiformis, and that name is confusing, so you should know about that. When they're talking about that entity, that's just pustular psoriasis in pregnancy. Okay, so now we're going to talk about the psoriasiform diseases, which will basically mimic psoriasis. So what are those psoriasiform diseases that mimic psoriasis? So number one is pityriasis rubra pilaris, and you want to write that down. So pityriasis rubra pilaris or PRP. The number two is seborrheic dermatitis. Number four is ILVEN. Number five is pale cell acanthoma. And then lastly, psoriasiform necrolytic diseases. So we're going to talk about all of this. So PRP, pityriasis rubra pilaris, is the second pityriasis entity, which is complicated, right? Now, the way you recognize pityriasis rubra pilaris is psoriasiform epidermal hyperplasia with a retained granular cell layer and no neutrophils. That's the first thing. That it is psoriasiform, but it is retained granular cell layer, no neutrophils, because psoriasis is psoriasiform with loss of granular cell layer and neutrophils, right? So that's one difference. But most of the times, PRP can be very, very challenging. The first thing which I look at it is that the psoriasiform pattern is not that prominent psoriasiform. So you have actually a very thick cornified layer, which is out of proportion to the thickness of the epidermis. So the epidermis is thick, but the cornified layer is thicker out of proportion. Okay. And you have what are known as the more rounded VT ridges, so more bulbous, rounder, fat VT ridges, and less of the suprapapillary thinning than what you see in psoriasis. Okay, so overall, the epidermis is psoriasiform, but it doesn't look perfect psoriasiform like psoriasis because it is not that thick. The VT ridges are fatter, they are plumper, and the suprapapillary thinning is not that prominent. The suprapapillary plates are actually thicker as compared to psoriasis. So I'm giving you multiple clues here. There is a psoriasiform pattern. Psoriasiform is not that prominent. You have bulbous, more rounder VT ridges, and you have suprapapillary plates, which are thicker. Okay, and your cornified layer is bright pink. Okay, the other feature in PRP is follicular plugging. So in PRP, you see that clinically as well. You get plugged follicles with parafollicular parakeratosis. So this plugged follicle with lipping on either side of the follicular ostium is a feature which is seen in PRP and seborrheic dermatitis. So when you get parafollicular parakeratosis or lipping of the follicular ostium, you will see that in PRP and in sebderm. Okay, so now let's look at some more slides of PRP. So you can see in here, this is a psoriasiform pattern But you see that there is a bright pink conified layer, which is out of proportion to the degree of the epidermal thickening, right? So you see there are more rounder ridgy ridges and the suprapapillary plates are thicker. And you have a bright pink conified layer, right? You have the, do we see a plugged follicle here? We do not see one in here, but this is the corresponding other piece of it. This is the follicular plugging. So you can see the plugged follicle with parafollicular paracavatosis in a bright pink conified layer. Okay, so that's PRP. Okay, now we look at more examples. I just showed you. Looking over here as well, this is psoriasiform, but it has a much more brighter pink conified layer. There is a plugged follicle here. You can see the fatter reedy ridges. You can see the thicker suprapapillary plates. There is retention of the granular cell layer. Okay, and this is what is known as the checkerboard pattern of cavatosis, which means there is alternating ortho, hyper, and paracavatosis in a horizontal and in a vertical and horizontal array. So if you go from top to top, bottom to top, or side to side, you are going to see mixed ortho, hyper, and para. Okay, they are not going to be distinct, sharp zones, contrast to what we are going to see in ILVEN. This pattern of cavatinization is the most confusing. So I don't expect you to right away recognize it. So you want to recognize it by the other features that I just told you, right? The psoriasiform acanthosis, the fatter reedy ridges, the thicker suprapapillary plates, retained granular cell layer, bright pink conified layer, follicular plugging. And then you do have the checkerboard pattern as well. Okay. Another feature which is described, which is a little bit more advanced for you guys, but which PRP can do, is that PRP can actually have some foci of acantholysis, which cells are falling apart. So acantholysis is something which we'll talk about later in blistering diseases, but that's when cells fall apart. So sometimes when psoriasis versus PRP is a confusion, we'll often get deepers. And if we see acantholysis, that will favor PRP over psoriasis. Okay. That's something it's like, if you don't want to remember, you guys can forget it. Okay, the next one is your seborrheic dermatitis. So seborrheic dermatitis, you're largely going to recognize it. It's not a really important board question. It is a psoriasiform pattern on the sites where the seborrheic areas of the body, which are recognized by prominent sebaceous glands and numerous villous hair follicles. So you know you're biopsying somewhere from the face or the head and neck area. And you see psoriasiform hyperplasia with the lipping of the follicular ostium, the parafollicular paracavatosis. Okay. Very often, I like to refer to this as like scalp psoriasis. So for example, like in this biopsy, if you said this is sebderm or psoriasis, is actually both. Because you see here, there is psoriasiform hyperplasia, suprapapillary thinning, loss of granular cell layer. So this is psoriasis, but you also see sebderm because you see parafollicular paracavatosis. So this is what is referred to as scalp psoriasis or sebo-psoriasis, wherein you see features of sebderm and psoriasis. This is more of a practical thing to remember rather than like a histology slide. Okay. So the next, however, important question that they do like to ask you is a pale cell acanthoma. So a pale or a clear cell acanthoma is a solitary lesion, which is a mimicker of psoriasis under the microscope, but clinically it's not. Clinically, it is a solitary lesion, which looks like a juicy erythematous papule, and you clinically are thinking about like a basal cell. And it has a nice psoriasiform acanthosis. It's sharply delineated from the surrounding epidermis, and you can see the nice massive suprapapillary thinning with these dilated vessels. So you see all the dilated vessels with the suprapapillary thinning. So these dilated vessels will actually produce you the classic dermoscopy finding of the string of beads appearance. It's pretty classic on your dermoscopy. And the lesion itself is composed of these large epidermal keratinocytes, which have lots of pale pink cytoplasm. And they have pale pink cytoplasm because that contains glycogen, because they have lost the glycogen phosphorylase, which is an enzyme which is going to degrade the glycogen, right? So all intracellular accumulation of glycogen will result in these large cells with this abundant pink, pale pink, cleared cytoplasm. So that's your pale cell acanthoma. A very, very important board entity. They love to test you. And it's pretty simple to recognize, right? A solitary lesion, thick, dilated from the epidermis, psoriasiform hyperplasia, and the dilated vessels with the clear cells. Okay. The next thing which we're going to talk about is your ILVEN, inflammatory linear verrucous epidermal nevus. So epidermal nevus is something which is present at birth or after birth. It can occur later in life as well, but it typically has a linear or a Blaschkoid distribution or a segmental distribution, right? So when you think about it, it could be epidermal nevus. Now, epidermal nevus could be varying kinds. It could be seborrheic keratosis-like. It could be ILVEN, which we're going to talk about. It could have segmental, like Darius disease-like findings in it. It could have epidermolytic hyperkeratosis. So, or it could be those are the most common type of epidermal nevi that we talk about. So inflammatory linear verrucous epidermal nevus is a psoriasiform kind of an epidermal nevus. So on biopsy, when you take it, the background epidermis is thick in a psoriasiform pattern as what you see in here. The bulbous VT ridges are suprapapillary thinning, you see that. But what you see is a very distinct pattern of cornification, and that's what makes the diagnosis. So what you see in here is alternating parakeratosis, orthohyper, parakeratosis, orthohyperkeratosis, parakeratosis, orthohyper, para, ortho, para, ortho. So you can see the nice alternating broad columns of orthohyper and parakeratosis. Wherever you see the parakeratosis, you have loss of granular cell layer. Wherever you see the hyperkeratosis, you have retained granular cell layer. So along with the alternating columns of orthohyper and orthohyper and para, you also have loss of granular cell layer, retained granular cell layer, loss of granular cell layer, retained granular cell layer, loss of granular cell layer, retained granular cell layer, right? So it's a very distinct pattern of cornification, and that is ILVEN. Do you guys get that? This is a really, really important board question. Okay, the next one, which we're going to talk about, the last thing in the psoriasiform diseases is psoriasiform necrolytic diseases. So psoriasiform necrolytic diseases are a group of diseases which all share in common some nutritional or metabolic deficiency. Okay, so all of them will present as psoriasiform desquamating erythematous eruptions. And the entities which fall in that category, you want to write that down, is necrolytic migratory erythema, which is your glucogonoma syndrome. Necrolytic acral erythema, which is associated with your hep C infection. Acrodermatitis enteropathica, which could be acquired or inherited zinc deficiency. Pellagra, which is your niacin amino acid deficiency. Niacin deficiency. Then Hartnupp's disease, which is your tryptophan amino acid deficiency. And then very commonly what we see is isoleucine amino acid deficiency, which happens because of either malnutrition or the patient has had like a bowel surgery or a short gut syndrome, anything which disturbs your gut flora. So that will result in a psoriasiform necrolytic disease. The histology of which, the bottom of which looks like psoriasis. So you can see that this looks like psoriasis, but the top looks like completely pale epidermis. There is pallor with confluent parakeratosis. The pallor is produced by this pale vacuolated keratinocytes. So you can see these really pale cells, and this is why this lesion will desquamate easily. So you can see how it will produce you a superficial blister because it will desquamate easily. So pallor of the top of the epidermis, how it looks pale with the psoriasiform pattern in the bottom of it. That's a psoriasiform necrolytic disease. So if you see this, they can ask you only one of those things in the differential unless and until they are following it up with the second order question. So this is a really high bold yield question, right? Because they can ask you about so many entities. So that's psoriasiform necrolytic dermatosis. Okay. Next one we are going to talk about is the next, we have covered psoriasiform, we have covered spongiolic. Now we're going to talk about lichenoid group of diseases. So the interface group of diseases, and we talked about this last time, are the group of diseases which have dead cells in the epidermis, necrotic cells. They are broadly classified as lichenoid and interface vacuolar. Okay. So both of them will have dead cells in the epidermis, but the pattern of inflammation is different. So in lichenoid inflammation, you have a band-like infiltrate, which is hiding the epidermis from the dermis. So you see this band of infiltrate. That's what is called lichenoid. Okay. The prototypic disease which produces the lichenoid pattern is lichen planus. This is nice lichen planus, where you get this band of inflammation hiding the epidermis from the dermis. the most important thing in lichen planus is this irregular, jaggedy, sawtooth acanthosis. So you can see this literally like these pointed witty ridges. So like in psoriasis, you have the bulbous, the fat witty ridges, the rounded witty ridges. Here you have the opposite. You have the sawtooth, the irregular, the pointy, the jaggedy witty ridges, as you can see in here. Okay. This irregular sawtooth acanthosis, you can see the wedge-shaped hypergranulosis. So there is a thick granular cell layer and it is in an inverted triangular form because the apex is here. So wedge-shaped hypergranulosis. Besides this, you see the hyperkeratosis, and the classic lesions of LP should not have parakeratosis. Okay, so you have lichenoid inflammation. You have the irregular, jaggedy, sawtooth acanthosis. You have the wedge-shaped hypergranulosis, the hyperkeratosis, and no parakeratosis. And what you see at the DE junction is all this vacuolar alteration. So you see the holes in spaces. Are you guys seeing that at the DE junction? And you see all these dead cells in the epidermis, necrotic cells, and these are called cytoid, civate, or colloid bodies. So these dead cells in the epidermis are cytoid, civate, or colloid bodies, are the necrotic cells. And there will also be some pigment dropout because whenever the epidermal cells die, they're going to release the pigment, right? So it's not infrequent in LP to have the pigment dropout. So let's see some more examples of lichen planus. This is another lichen planus. So you can see the beautiful band of inflammation. Does everybody recognize that? You see the very nice jaggedy, pointy, sawtooth acanthosis. Beautiful wedge-shaped hypergranulosis. You can even see that at this power. This hyperkeratosis, parakeratosis. These are your cytoid or civate bodies, which are your dead cells. More of them over here. You see there is pigment dropout. So when lichen planus will resolve, it will leave behind the pigment dropout, which will produce lichen planus with post-inflammatory change. Okay. Sometimes in lichen planus, because of the excessive destruction of the DE junction, you can get secondary subepidermal blister formation, which is called max Joseph space. So let's have a look at that. Where is your, so like here, you can see here, there's focally, there is subepidermal separation. That's called a max Joseph space. So secondary subepidermal blister from your lichenoid inflammation is a max Joseph space. Probably have a better example of it. Don't have it in here. When we'll do blistering diseases, we'll see more, but you got the thing, right? When there is secondary subepidermal vesiculation from lichenoid inflammation, that's your max Joseph space. Okay. Now let's talk about lichenoid drug eruptions. So lichenoid drug eruptions are the most common drug eruptions that you encounter. And anything under the sun, ACE inhibitors, beta blockers, calcium channel blockers, diuretics, anti-epileptics, anti-diabetics, which most of your patients are on, will produce lichenoid drug reaction. So lichenoid drug reactions are kind of indistinguishable from lichen planus, but some of the clues that you're dealing with the lichenoid drug reaction is when you are seeing LP-like features, because you see the band-like infiltrate and the sawtooth acanthosis, but you see aberrant features. So what are the aberrant features? A, you will see there's parakeratosis. There is spongiosis in the epidermis. So you see prominence of the desmosomes, there's spongiosis in the epidermis. And then there are eosinophils, which normally you don't see. You can see a couple of eos in LP, but you should not see like a whole lot of eosinophils like what you are essentially seeing in here. The prominent eosinophils in the biopsy. You have a deeper infiltrate. So typically in LP, you just have the band of inflammation. You should not get perivascular inflammation. So if you have perivascular inflammation, which is going deep, and especially the one that has eosinophils, so those all things will make you think about lichenoid drug. So something that looks like LP, but is a little different from it because A, you have the you have the spongiosis, and you have dermal eosinophils with a deeper infiltrate. That makes you think about lichenoid drug. Okay, so the next thing which we are going to talk about is the other lichenoid diseases, which is very common. Number one will be your lichen striatus. So lichen striatus is another disease. The other name for it when it happens in adults is adult blaschitis. It often has a linear segmental distribution, and its histology is classic. It's a very important board entity, a high yield board entity. what you see is the lichenoid pattern of inflammation on the top with the superficial and a deep perivascular lymphocytic infiltrate. So you see the nice tight infiltrate, but the overlying epidermis has this lichenoid pattern of inflammation. And most importantly, you see inflammation around the sweat gland. So you see periicrine inflammation. So periicrine inflammation with the superficial and a deep lymphocytic infiltrate with the lichenoid pattern of inflammation is lichen striatus. Okay. The next entity which we're going to talk about is going to be lichen nitidus. So lichen nitidus is characterized by this tiny papular eruption involving the flexures or the trunk or the genitalia. And what you see are these tiny lichenoid pinpoint papules. And each of this papule corresponds to like a couple of dermal papilla with the club-shaped expansion of rete ridge on either side. So it's a ball and a claw pattern. So this is the ball, and this is the claw that is grabbing it. So ball and a claw pattern. So you can see the claw of the rete ridges, which is grabbing the lichenoid infiltrate in the dermal papilla. Now, often the lichenoid infiltrate in the dermal papilla actually has histiocytes and giant cells. It's not uncommon in lichen nitidus for this to be a granulomatous infiltrate, okay, which has giant cells and histiocytes, as you can see in here. So do you all see the ball and the claw here? This is pretty classic for lichen nitidus. Okay, then the last thing in lichen planus that I'm going to talk about is hypertrophic LP. Hypertrophic LP is a disease entity which is going to clinically mimic like a squamous cell. It most commonly occurs in the lower extremities. And what you see is a variant of LP with a lot of epidermal acanthosis. So you see a very thick epidermis, and you also see the hypergranulosis. The lichenoid pattern of inflammation may die off. But what is left behind is again this jaggedy, irregular sawtooth acanthosis. And you look at the bottom at the DE junction, you can see the nice vacuolar alteration and the necrotics. And then there is going to be the pigment dropout. Okay, so this is hypertrophic LP. Okay, so then you have the thick epidermis with the wedge-shaped hypergranulosis, the irregular sawtooth acanthosis. So remember, the band of inflammation can actually subside and it can die off, which is fine. But you do see at the DE junction, you will be able to see the necrotics and the pigment dropout. So that is hypertrophic LP. Hypertrophic LP is much more board testable than hypertrophic lupus. That one is a much more difficult diagnosis. The histology can look kind of really similar, but remember that it's much more common as hypertrophic LP than hypertrophic lupus. Okay. Now let's come to your next group of diseases, which will be your interface vacuolar. So interface vacuolar diseases are the group of diseases wherein you are basically getting vacuolar alteration without the lichenoid infiltrate. So you're getting the holes and the spaces in the DE junction. You have seen the holes in the spaces with the dead cells. Now, interface vacuolar is classified as acute and chronic, but that doesn't mean the onset in the patient. It means what are you seeing under the microscope? So what does chronic interface vacuolar mean? It means when you're seeing epidermal atrophy with effacement of the rete ridge pattern. So you don't see rete ridges, so that's epidermal atrophy. You see hyperkeratosis, but most importantly, you see a very thick basement membrane. The basement membrane begins here, it ends over here. Okay, so you see epidermal atrophy, the hyperkeratosis, effacement of rete ridge pattern, and a very, very thick basement membrane. And along with this, whenever you have chronic interface, because the DE junction has been insulted a lot, the basal epithelial cells, they start actually looking like little atypical because they have reactive atypia. And that is what is referred to as squamatization of the basal layer. It looks almost like an actinic keratosis. Okay, so all these features of chronic interface dermatitis, wherein you get epidermal atrophy, the hyperkeratosis, the thick basement membrane, is classic for a connective tissue disease. So when you see this, you are in a connective tissue realm, which could be either lupus or dermatomyositis, and you really cannot tell apart lupus and dermatomyositis based on your slides, based on the histology. You have to be able to correlate it clinically and with serology studies. Okay, So a connective tissue disease equals chronic interface dermatitis, which equals lupus or dermatomyositis, wherein you see the epidermal atrophy, the effacement of VT-rich pattern, hyperkeratosis, and this thick basement membrane with the squamatization of the basal layer. So let's see more examples of chronic interface. So you can again see here, you can see the nice holes and spaces, vascular alteration. So is it acute or chronic? This is beautiful epidermal atrophy because you don't see any feet of the epi holding it into the dermis, effacement of radial ridge, hyperkeratosis. You can see how thick the basement membrane is. We can see how it ends here. Very thick, fuzzy looking basement membrane. There is squamatization because it looks like reactive epithelial atypia. And so this is a connect. And then all connective tissue disease mostly have dermal mucin, but mucin is not required for making the diagnosis. If you see mucin, it substantiates your diagnosis. If you don't see mucin, that is okay. And if you only see mucin without the other changes, then you're still not going to call it a connective tissue disease. So, but this has mucin. So mucin is this like really stringy material, which is present in between the collagen bundles. It often looks like the dermal collagen fibers are separated. This is not mucin. This is solar elastosis. So very often you guys get confused with mucin and solar elastosis. So you have to be absolute. Mucin is not that readily visible. Like this is forming the fried up connective tissue fibers. Okay. This is mucin. Say a subtle blue thing in the dermis, whereas this is solar elastosis. Okay, so the main type of connective tissue diseases that we deal with are lupus and dermatomyositis. And as I said, that both of them are indistinguishable, right? And lupus erythematosus in the skin could be chronic discoid lupus, subacute cutaneous lupus, and systemic lupus erythematosus. So all the three types, again, cannot be distinguished based on histology, but there's some, like they still try to ask you, like the chronic slides of chronic discoid lupus, because they have a very classic look to it. So chronic discoid lupus, so unlike other organs where you go from acute and chronic, the inflammation subsides, but lupus is opposite. So chronic discoid is the most inflamed, subacute cutaneous is in between, and systemic lupus is the least inflamed. And so is dermatomyositis. So systemic lupus and dermatomyositis are going to be the least inflamed. So this is your classic side of chronic discoid lupus, wherein you should be instantaneously be able to recognize it. You have a superficial and a deep lymphocytic infiltrate, which is also perifollicular in distribution. You can see that there is nice epidermal atrophy. You see a very thin epidermis. There is hyperkeratosis. You actually see a very thick basement membrane in over here. But most importantly, look at how superficial deep lymphocytic infiltrate is around the follicles. You get follicular plugging. Okay. And there is even some very subtle mucin in this slide. Let me show you more examples of chronic discoid lupus. This is another one of chronic discoid lupus. Should be instantaneously be able to recognize it. You have the nice superficial deep infiltrate. You see beautiful plugged follicles, follicular plugging. The epidermis, it is thinned out in some areas. And again, in chronic discoid, sometimes the interface changes may not be that obvious, but you're mostly recognizing it by the dense infiltrate and the follicular plugging, but you will be able to see some interface. So you can see vascular alteration. There's actually very thick basement membrane in here. Okay. And then there is very nice mucin in this slide. So that's chronic discoid lupus. Subacute cutaneous lupus is less inflamed. In subacute cutaneous lupus, which could be idiopathic or drug-induced, the Rho and the La-mediated form of lupus. And what you see in here is, again, you can see that this is an interface dermatitis, right? Why? Because you see the holes and spaces. You see the necrotic cells, so it's interface. So now the next step is to classify it as acute or chronic. And yep, it is chronic. Why? Because you see the atrophy, you see the hyperkeratosis, and you see a very thick basement membrane. It begins here, it ends here. Begins here, ends here. You can see it's completely fuzzy and thick. And along with this, you have accompanying perivascular inflammation around the vessels. and probably inflammation around the hair follicle. I cannot show that in this section, but there is inflammation. And there is very nice mucin in the slide, which confirms it. Okay, so this is subacute cutaneous lupus. Lesions of systemic lupus and dermatomyositis can be pretty much similar. So systemic lupus and dermatomyositis are both like quasi-inflammatory. They don't have a lot of inflammation. So when you look at it in low power, they do not look very inflamed. But you can clearly see the beautiful chronic interface, right? You can see the holes and spaces, the vacuolar alteration, the necrotics. Look at how thick the basement membrane is. Begins here, it ends here. Begins here, it ends here, right? So there is atrophy, hyperkeratosis. You don't see a whole lot of inflammation, which is very classic for the Okay, so we were talking about, what were we talking? That's SCLE, right? Systemic lupus dermatomyositis. So it's very quasi-inflammatory. You don't see a whole lot of inflammation, but you can see the chronic interface change, the vacuolar alteration, the necrotics, a very thick basement membrane, the atrophy, but you see, you barely see any inflammation. This is pretty typical for systemic lupus or dermatomyositis. You will be able to see, this can be subtle, some mucin in the dermal interstitium. Now, one of the important things that they like to test you on is your is Gottrin's papule. So let's look at Gottrin's papule. So when we were talking about the thick skin differential diagnosis, this is Gottrin's papule. Yeah. So, the things that we have talked about on acral skin is pernio. We have talked about dyshidrosis or Pomphylix, and Gottrin's papule is the next. So Gottrin's papule, it's a chronic interface lesion of dermatomyositis, right? So what you are going to see in here is going to be, this is the acral skin, but you actually see epidermal atrophy and hyperkeratosis. You see, it's not going to be very prominent vacuolar alteration, but you do see the fuzziness, the thickness of the basement membrane. There's actually some mucin in the slide, and you see perivascular inflammation. So the features of Gottman's papule can actually be really subtle. So the clues that you're looking at, it is thick skin, it's acral skin, but the epidermis is atrophied. You're seeing hyperkeratosis. You don't see the Baskerville stratum corneum. You see the vacuolar alteration, and you see the necrotics with the thick basement membrane. And you also see some mucin with perivascular inflammation. So that's Gottrin's papule. That's a very important board entity. Okay, now let's talk about some specific kinds of lupus, which is going to be this particular one. This is really important. We're going to be talking about this entity multiple times, and this is a superficial and a deep lymphocytic infiltrate, which is what I'd call a lupus-like infiltrate. It's a very tight lymphocytic infiltrate. Notice that the epidermis is unaffected. There is no epidermal change. Okay, so this tight lymphocytic infiltrate is called as coat sleeving. Okay, so a coat sleeving infiltrate, sleeve-like infiltrate, very tight, dense lymphocytic infiltrate around the vessels is what you see in here. Now, this pattern of superficial deep lymphocytic infiltrate without the epidermal change, there should be no epidermal change whatsoever, along with dermal mucin. When you go up on high power and you see, oh yeah, there is some dermal mucin is seen in tumid lupus. So what is tumid lupus? So tumid lupus is a type of lupus which occurs on photoexacerbated papular eruption. You really don't think clinically about lupus in that. And you see a superficial deep tight lymphocytic infiltrate, which is a coat sleeve pattern with dermal mucin, with subtle dermal mucin and no epidermal change. Okay. When you see the pattern of this tight sleeve-like infiltrate, you think about tumid lupus and you think about gyrate erythemas. So gyrate erythemas are a group of diseases which all have overlapping features of a clinical presentation of a polycyclic arcuate annular erythematous eruption. And under the category of gyrate erythemas are diseases, number 1, erythema annulari centrifugum. Number 2, erythema gyratum repens. Number 3, erythema chronicum migrans, which is your rash of Lyme's disease. Number 4, erythema marginatum, which is your rash of rheumatic fever. And number 5 is Yesner's lymphocytic infiltrate. So EAC, erythema chronicum migrans, erythema gyratum repens, Yesner's lymphocytic infiltrate, and erythema marginatum. So all of those are your gyrate erythemas. Now, out of that, the only distinguishable entities is both testable is going to be between tumid lupus and EAC, because all the other entities that I talked about in gyrate erythemas, they have non-specific findings. They have variable degree of epidermal changes. So if you see a tight lymphocytic infiltrate like this, superficial deep tight lymphocytic infiltrate with mucin, that is tumid lupus. If you don't see mucin, that's EAC. Okay. And the EAC we are talking about is the deep variant of EAC. We're not talking about the superficial variant of EAC. We're talking about the deep variant of EAC. And please look up the associations of all these diseases. Those are very high yield. EAC is associated with a ton of entities. Erythema gyratum repens is associated with a ton of entities. So you need to, that can occur as a paraneoplastic manifestation. So you guys need to know about that. Okay, so next, I'm going to quickly talk about the scarring alopecias from lupus and lichen planus. So scarring alopecias will always have, when you're dealing with the biopsy from alopecia, they will be horizontal, round biopsies like that. Okay, it's a scarring alopecia. Why? Because I don't see sebaceous glands. So when I don't see sebaceous glands, I know that I'm dealing with a scarring alopecia. And when you see a lot of inflammation around the hair follicles, that's more lupus. So lupus has perifollicular inflammation rather than LPP, which I will show you, which has perifollicular fibrosis. And in lupus, scarring alopecia from lupus, the entire overlying epidermis is involved. Okay. Now, this is going to be in contrast to your lichen planopilaris, wherein you again have the scarring alopecia, because it's a round section, you don't see sebaceous glands, so it's a scarring alopecia. But you notice that around the hair follicles, instead of perifollicular inflammation, you have this perifollicular fibrosis. So do you see that? But the fibrosis is more prominent than the inflammation. So you can see this is beautiful perifollicular fibrosis, which is more common than inflammation. And only the portion where the hair follicle is attached to the epidermis is going to be affected. So the interfollicular epidermis is normal. So this is a beautiful mucinous perifollicular fibrosis rather than inflammation of lichen planopilaris rather than of discoid lupus. Okay. Then lastly, we are going to talk about is your acute interface diseases. So in your acute interface diseases, basically comes GVHD, erythema multiforme, fixed drug eruption, and pityriasis lichenoides. So GVHD is going to be one of your invisible dermatosis. So in GVHD, you get an acute interface dermatitis. This is not GVHD. Let's see. It's basically you don't get any much inflammation whatsoever. So when you look at the biopsy, the only thing which is happening in here are like the dead cells in the epidermis. You don't get anything else. It's very post-inflammatory. That's acute GVHD. Now, chronic GVHD is different. Chronic GVHD is of two kinds, of lichenoid and sclerodermoid. So chronic GVHD can look indistinguishable from lichen planus or indistinguishable from morphia, which we will talk about. What we are talking about is acute GVHD, wherein you only get is the vacuolar alteration and the dead cells in the epi with no other change, with no other inflammation. More important are going to be your, basically your EM and fixed drug eruption. So both EM and fixed drug eruption are acute interface dermatitis, wherein you get an intact stratum corneum, no thickening of the basement membrane. Okay. And you have all these necrotic or dead cells in the epi. You see the vacuolar alteration, and you see the necrotics or the dead cells in the epi, which are at varying levels with an intact stratum corneum. Okay, both EM and fixed drug can have variable degree of dermal edema and spongiosis. So both EM and fixed drug will look similar. It's as if somebody is sitting deep down in the dermis and shooting at the epidermis, wherein you get these dead cells in the epidermis at varying levels with an intact stratum corneum. So how do you distinguish between EM and fixed drug eruption? So this is again another example of EM, where you see a very acute stratum corneum and intact stratum corneum. You see all these dead cells. In the epidermis, they're at varying levels, and you do not have any thickening of the basement membrane. So that's EM or fixed drug. Now, the way you will distinguish it is you will want to look at the degree of your pigment dropout. Okay, so if you're seeing a substantial, easily recognizable pigment dropout, like what you see in here, okay, along with the eosinophils, more than the eosinophils, you can see a couple of eos in EM, it's a pigment dropout. If you see prominent pigment dropout and you're seeing eos, then for sure you're dealing with fixed drug eruption. But I like to look at the more degree of the pigment dropout. And you can see in here, this is beautiful intact stratum corneum. You can see the vacuolar alteration. You can see the necrotics at varying levels, variable degree of dermal edema. Okay, so that is fixed drug eruption. Now remember that both EM and fixed drug eruption, they will basically have a phase in which they can produce you confluent epidermal necrosis. So let's see if I can find a slide in here of that. Okay. So what happens in both EM and fixed drug eruption is that over a period of time, the vacuolar alteration and the necrotics will become confluent and will produce you confluent intraepidermal necrosis. That will produce you an intraepidermal blister. So this is what is known as a lacy epidermal sign. And we'll talk about this more in your blistering diseases. You have a dead epidermis juxtaposed beneath an intact stratum corneum. So it looks like a lace. A dead epidermis beneath an intact stratum corneum. That is because of interface-mediated epidermal necrosis. You can see where the epidermis is more intact. You can see all these necrotics which are becoming confluent. So you could see this in bullous EM. You could see this in bullous fixed drug. You can see this in EM major, Steven-Johnson, TE, and you could see it in any of those entities. So the only way you can tell them apart is by using the clinical. And we'll talk about this more when we do the intraepidermal blistering diseases. Okay, so this is bullous EM or bullous fixed drug eruption. Because it has a lot of pigment dropout, I would say that this is probably bullous fixed drug over bullous EM. The last acute entity which we are going to talk about is basically pleva. So this is the last pityriasis diseases, which is again complicated, right? Pityriasis rosea, pityriasis rubra and pityriasis lichenoides. This is a beautiful lesion of pleva. The way I think about pleva is that all the layers of the skin are affected from the top to the bottom. So when you start at the top, you will get the paracavatosis. And going from top to bottom, you have a wedge-shaped lymphocytic infiltrate. So that's the other way of approaching it. You have a superficial deep lymphocytic infiltrate, right? But in pleva, remember, if you go up on high power, you will not see any eosinophils, right? And you're substantiating it because from top to bottom, you get everything. You get the para. Very important is this point. Notice how there are prominent limbs in the epi. This is called lymphocytic exocytosis, a satellite lymphocytosis. A lot of prominent limbs in the epi is a very classic finding of pityriasis lichenoides. The crust, the limbs in the epi, spongiosis. The necrotics will be there, but they will not be that prominent. Some vacuolar alteration. What will be very prominent is the limbs in the epi. Then come down, there is dermal hemorrhage. And you have the wedge-shaped lymphocytic infiltrate. So that is your pleva. Okay. So with that, we have ended our spongiotic psoriasiform and interface. I'm going to be sending you guys some multiple study sets. I am going on vacation on Wednesday, and I'll be gone. I'll be back in early August. I'm going to Japan, so you're going to be missing 2 classes, but I'll have work outlined for you guys. So for the next week and for the week after. So I want you guys to work on that. And then when I come back, we will jump into some marathon sessions, but I will have work outlined for you. So it's not like you're not going to have any work. You're going to have plenty of work. So I will expect you guys to finish that work.
Okay, thank you so much. Safe travels. Thanks for getting on here.
Thank you.
How pretty it is here.
What was that?
You see that?
Oh, wow.
That's so beautiful.
That is whale in the summertime.
404.
Wow.
It's beautiful.
Gorgeous.
Love coming here in the summertime. Yeah.
Enjoy. Thanks for coming
Okay.
on during your conference.
Yeah, no
thank
worries. You guys have a good weekend, all of you.
you.
Thank
Thank
you.
you.
Michelle, did you
too.
get your ID?
Yes, I did.
Okay.
I have
and-
mine and Angela's.
Thank you.
Okay, perfect. And for us, you'll be in next week, right? On Monday?
Yes, I'll be there Monday.
So you'll get your ID on Monday.
Thank you so much again, Dr.
Okay. Thank you. Bye.
Thank you.
Bye. Thank you.